So this condition, first of all, you must know about the anatomy of the rectum. We have discussed earlier in many lectures about the anatomy of the rectum. So I will give you some details. Rectum has a three layers. The most inner layer is the mucosa, then submucosa, then a muscular coat. So all the layers are making up whole rectum. So if only the mucous membrane showed up, shows up from the anal verge into the type which is called partial prolapse. But if the entire rectum comes outside of the anal verge, this is also called complete prolapse. So that the condition is a common. This condition is a common in children and elder patients. The elder patients are those who has more than 60, 50 years old, and children, most younger children. So types: the partial prolapse and complete prolapse. The partial, in which the only mucous membrane comes out from the anal verge, and the complete shows up in the whole outside, the whole wall of the rectum comes outside the anal verge. So now etiology. Why it happened? Why it causes prolapse? Because of a decreased sacral curvature and decreased anal canal tone. These both probable causes in infants. An infant who has a decreased curvature of sacrum. The sacrum is the area which is holding the rectum. Because in a rectosegment junction, there is a sacral promontory is a area. Sacral promontory is the area where the rectum is held. So the sacral curvature is basically a main cause to hold the rectum. If it decreases in its curvature during the development, embryological development of baby, or the decrease in anal canal. Anal canal is basically controlled by the sphincters, by the uh, levator and eye muscles, the puborectalis. So these are the reasons which causes decrease. So it in infants. Second etiology is the diarrhea, cough, malnutrition. This is basically a dietary factor or the additional factors in children. Those patients who have a diarrhea, that means a mobility, a further mobility. It causes the mobility of the rectum so that it can cause the prolapse. A cough is basically reason because of abdominal pressure. If if a child who coughs, who creates a positive abdominal pressure, the more pressure, the more percentage to suffer from the prolapse. Malnutrition. Malnutrition is because some protein, some fats. You know about the fat. You know about the proteins. These are the factor. These are factor making a whole body in a tone. If you are decreasing the nutrition, you are basically decreasing the tone of the body. So the malnutrition is the additional factors. But the most main cause in infants, it's a sacral curvature decreased and decrease in canal tone. So these are two main factors. Another etiology may be due to a reduced ischiorectal fossa fat. Again, it is related with the malnutrition. If the patient is a child, if it's infant who suffering from the malnutrition, who suffering from the malnutrition disease, who suffering from the malnutrition, it reduces the ischiorectal fossa fat. Any neurological causes, any neurological causes which can decrease the anal canal tone. It, fibrocystic disease of the pancreas, fibrocystic disease of the pancreas mostly associated with the malnutrition, and the poorly developed pelvis. So it is again associated with the decreased sacral curvature. So you can if you if you face any problem to remember these as etiology, so you can link these all with only two: the decreased sacral curvature and decreased anal canal tone. In adults, it is a common in a female, common in a multipara, a repeated birth injuries to perineum. So these in adults is the most common. I feel why the in adults a question a question come to you, why it is a common in a female. You can answer, and that because the female can go multipara can go on repeated birth injuries to perineum. So that's why it can cause. It is the most common in a female. And if you're talking about what happened, what may happen to the birth if injury happens to perineum, so what happened next, because it damages the perineal nerve, so that's why it can cause the prolapse. So the reason is that reason is what perineum is basically a nerve which supply the muscles, so that's why it loses the tone, loses it causes the prolapse. Now, it is a due to a weakening of a supporting tissue and levator muscles. I have discussed earlier. I talked about the levator muscles, puborectalis muscles. These are the muscles which causes the tone of sphincter. Increase intra-abdominal pressure due to any cause like chronic cough and stricture urethra. So, this is a cause which is causing. Either it is weakening the sphincter, or either it is creating abdominal pressure. So the intra-abdominal pressure can be caused not only just cough, but stricture in the urethra. The stricture in the urethra occurs in a UTI, in a urethral injuries, and any stone which can cause scar. And a scar makes a fibrotic stricture in the urethra. It is decreasing the urine, and due to the stricture, it can increase intra-abdominal pressure. So that all you can link the etiology with any two: decreased sacral curvature or decreased anal canal tone, and associate factors which can cause which can create intra-abdominal pressure or atony of sphincter or weakening of supporting tissue. So as we discussed about the partial prolapse, so here only mucosa and some mucosa of the rectum descends. As people mucosa and some mucosa not more than 3.75 centimeter, round about 3.8 centimeter or 4 centimeter. You know about the 4 centimeter? How would you calculate the 4 centimeter? Simply, you can see here the one finger breadth is basically about a 2.5 centimeter. It's not more than two finger breadth. It's not more than two finger breadth. So if you see any patient comes to you and saying there's something coming out from the anus, and you can examine by yourself, and you see there is a area which is only about two finger breadth, and you are diagnosing it's a prolapse. Now but you have first you inspect the patient, you see the perianal region, and you diagnose its prolapse. Now now you are going to confirm either it is a partial or complete. You have to just to see its size. It is not more than 4 centimeter, around about 3.8 to 4 centimeter, like two finger breadth. There is no descent of the muscular layer, and it is the commonest type of rectal prolapse. So if you see there is a two only 4 centimeter, and so you will confirm you will confirm by yourself it's a partial prolapse, and it is the most common type of rectal prolapse. And it doesn't lead to a muscular layer to come from the anal verge. Okay. So what are the clinical features? History is a mass per annum. A patient comes to you and will say something coming out of the anus, which can be observed when child is allowed to stand in squatting position. How a, a patient comes to you and he will say, a child comes to you, he will say that, "Okay, I have something." Her parents, her or his parents will say to you, uh, "There's something coming out from my child," and so you can ask the child to sit in a squat position and strain it. So you see there is something coming out from the anus. There is something mass like a mass coming out from anus. So it would be a pink in color because mucosa and submucosa is a pinkish color, and the circumference and the whole circumference, as opposed to the hemorrhoid. Hemorrhoid is a radially projecting from anal area, and mucosa comes direct in a pinkish color. So you can differ from the piles. The piles are not circumferential; they are a palm, and they are not pinkish. They are palm or blue colored, like a van, like a van, like a sports. Clear? So what are the treatments now for the partial prolapse? Now you can know about the treatment. What are the treatment of the partial prolapse? You can know. They are the basically infants. There are different treatment modalities. There are different treatment modalities. So it is a you must know that the diagnosis is basically totally upon the clinical. You can diagnose through a clinical. Now the treatment in infants and young children. It is a two. It is a either you can go for a digital repositioning, either you applying a injections, submucosal injections, either you're going to the surgery. In a digital repositioning, the parents are taught to replace the protrusion and any underlying causes are addressed. If a patient is a if a child is a malnutrition, you can give him a good nutrition. You have asked to feed up very well, and asking them to position again to position the mucosa inner side. This is a simple. It depends upon the condition of the child. It depends upon the prolapse area and the duration of the area. How many days, how many time has been spent with this disease. So that's why number one you can apply the digital repositioning. Second is submucosal injections. If a parents tried to do a digital repositioning but it fails after almost 1 month trial, 6 weeks trial, then injection of 5% phenol in almond oil are carried out under a general anesthetic. As a result of a septic inflammation following these injections, the mucous membrane becomes tethered to muscle to the muscle coat. That means that a parents tried for the digital repositioning, but it fails due to some reason because the duration of the prolapse, either they are not positioning very well, either the patient is not getting good food, either other causes are missed, other causes are not addressed well. So the submucosal injection you can apply in area which causes an inflammatory reaction to the muscle cord, and muscle cord causes the inflammation. The inflammation starts between the muscle cord and submucosa, and it tethered the submucosa with itself with the muscle cord. So the 5% phenol almond oil is the injection which applied in the submucosa area. Almond oil and 5% phenol. What does it mean? That means that phenol has only 5% in its concentration, and almond oil is that which keep the solution with intact itself. It not dispersed. So it's not dispersed. So that's why they are always mentioning. They are all uh, and so the digital repositioning we have the patient attendants, patient parents have to apply digital repositioning for the 1 month. If it fails, then we can go for a surgical injection. Now, surgery, well, occasionally surgery is required in infant and young children. It's now different modalities has been different applied. Young, and we are talking about only the infant and young children at this time. So the surgery is not needed. Is rarely needed. Is occasionally needed, occasionally required in infant and young children. The child is placed in a prone other. So if it needed, So the child is placed in a prone jackknife position. The retrorectal space is entered, and the rectum is switched to sacrum. It's a rectopexy basically. So we can go for the. So it is a basically a perineal surgery. You can it is a basically a perineal surgery, and simply through the through the retrorectal space apply the rectum, apply the suture between rectum and sacrum. Simple. But it is rarely needed in the infant and the young children, because you can apply the mucosa, because young children is basically in a development phase, and you can do the parents can apply the repositioning of the mucosa. It will it will itself placed in that position. Either submucosal injection is successful after 1 month, but trial. If you're talking about the adults, the local treatments, and there are the two modalities: the local treatment and excision of the prolapsed mucosa. Local treatment, submucosal injection of phenol in albumin simply with that, or the application of rubber bands are sometimes successful in cases of mucosal prolapse. Simple local treatment, you apply the 5% phenylalbumidine, either you are applying rubber bands. Excision of the prolapse mucosa. When the prolapse is a unilateral and the reduced mucosa can be excised, if circumferential endoluminous technique can be used. So excision is not always a choice, because as a unilateral you can go for the excision. You can excise the extra mucosal part which is coming out from the anal margin. But if the whole circumferential, you can go for the stapling. You can apply the mucosa in position, in the upper position, in the inside of the anal, inside of the anal area, and then apply the endoluminal stapling. So now that all about the partial prolapse. And partial prolapse, we have applied these measures to manage it. It's a now complete. Now we have discussed the partial, which was only 4 centimeter, around about 3.8 centimeter. The it's a complete prolapse. It's a basically a prosynecia. They are less common than partial. Number one, it is a common in female. Again, 6:1 like ratio, like a 6% of we're talking about the female and male ratio is a 6:1. It is due to a weakened liver and supporting pelvic tissue. Always more than, it is always more than 3.7 centimeter, more than 4 centimeter, more than 2 finger breadth, and all layers of the rectum area, including a muscular. Up to the, and it can up to the 10 to 15 centimeter. The whole rectal, whole, if you're talking about the whole rectum length, is a 10 to 15 is a 15 centimeter, and it can descend to 15 centimeter whole of the rectum from the anal area. It is often associated with the uterine descent, uterine prolapse. So it is a, if we are talking about the weakness of the levator muscles, so it can cause other structures which are lying in the pelvic region to descend. So uterine prolapse is also common with the rectal prolapse. Once it is also thought to be the an intussusception of the rectum, because rectum has a 3 regions: upper, middle, and lower. So it can be a upper middle region can be intussuscepted with the lower margin, or upper rectum can be doing middle rectum. Once complete prolapse is more than 5 centimeter, once complete prolapse is more than 5 centimeter, anteriorly it drags peritoneum as a pouch which often contains small intestine. On digital pushing, the reduces with a gurgling. So if you see there is a complete prolapse more than 5 centimeters, it could be a reason which causes the peritoneum to drag with itself, and in a peritoneum there would be a small valve. It can cause the gurgle sounds while digital pushing. So the petilous anal sphincters are typically with the mucus discharge and fecal incontinence. Is a clinical feature. A mucus discharge, fecal incontinence. This is a clinical feature. Patient always complain of that thing. And so what are the etiology factors? Weak anus, external sphincter and pelvic muscle. Next, So these are the reasons which can cause the complete prolapse. You can see, you can see here, you can see here the rectum. You can see sacrum curvature. This is sacrum is a leaky curvature of sacrum. You can see here a prolapse. This one area you can see here, pinkish color, less than 4 centimeter. Pinkish sacrum fissure. Okay. Here now, if you see here, there's a complete prolapse area which shows the more than 4 centimeter in size and shows the so in etiology you can see here, you can see here the complete prolapse. This is called squat position. You ask a patient, you ask a child to sit in a squat position and strain it. It will show you through. So the weakness of anus, external sphincter, pelvic muscle, mobile lexing of the mobile lex, mobile rectum, obliterated anorectal angle, abnormally mobile rectum with descent. Etiology is a complete feature. Clinical features are there. The complete descent of the rectum, which is basically a red in color, which and the partial was a pink in color, and often a painful and a mass per annum. Fecal incontinence is a very common. It is due to the disruption of anal sphincter and prolapse rectal mucosa discharge. Pain per annum, bleeding can occur because of congestion, sepsis, discharge, fever, anemia are the other features. It can cause sepsis, it can cause discharge, it can cause fever. But it shows the lex sphincter and clearly peritoneal say come down to the pouch which may contain a small bowel. So these are the clinical feature of the complete prolapse. One, the size is more than 4 centimeter, like a 5-6 centimeter. Incontinence is a common. Painless bleeding can occur, pain per annum can occur, and sepsis, discharge, patient has anemia also featured. On rectal examination, you can see the sphincters are very lax because sphincters are not working. And also the anteriorly, if you push the finger anteriorly, you can feel the peritoneal sac which comes down as a pouch and contains a small bowel. How? What are the investigation you can go? This is for the complete and partial. Now, okay, what investigation you ask a patient to do is that deficography reveals a mobility of rectum. You can see here, you can see in this area, it is the anterior part and this is the anterior part, this is the posterior part. You can see the peritoneum is come as a pouch and it contains, this peritoneum contains small bowel. When you're pushing this peritoneum inside of the anal verge area, and you can feel the gurgling sounds because of the small bowel in this peritoneal pouch. So now comes to the investigation. Deficography, what it reveals the increased mobility of the rectum from the sacral fixation point with the redundant with the mesorectum and the funnel formation. It is a fluoroscopic and spot filming in lateral projection after installing a radio-opaque material into the rectum done in sitting posture over a radiolucent commode. So in deficography investigation, it shows you the mobility of the rectum from the sacral fixation. There is a part of the sacrum which fixes the rectum. It shows the increased mobility of the rectum. So with the redundant mesorectum and the funnel formation. So the extra mesorectum part which shows you the and it shows the funnel formation. It shows you the funnel type area, projected area, and downward to the anal verge. It is a fluoroscopic and spot filming in a lateral projection. It is a fluoroscope and spot filming in a lateral position. Patient when you sit in the lateral position, it shows after installing the radio opaque material into the rectum done in a sitting posture over a radiolucent commode. Cinedeficography is a triple contrast. It basically dynamic MRI. This is a different investigation of different investigation you can go for the prolapse. Cinedeficography, triple contrast cinedeficography, dynamic MRI deficography, colpocystodeficography, and are helpful to delineate the complex pelvic floor problems. It is also, it is not just to these investigations are not just for the prolapse of the rectum, but it also helps in a it also helps in the pelvic floor problems. Like you can see the pelvis Pelvis. What are the abnormalities are related in the pelvis? Either it is a either it is related to the levator muscles or sphincters or any related structures which are around the rectum. So the difficography abnormalities, the mega rectum. Now, what are the difficography abnormalities? How would we do a difficography? Simply, it is a fluoroscopy. It is a fluoroscopic investigation. It applies the contrast, red opaque. It applies the contrast or red opaque material, which you can describe, which you can see in the simple X-rays, fluoroscopic X-rays. So, what are the abnormalities you can find in difficography? You can see a megarectum, incontinence, non-relaxing puborectalis, abnormal perineal descent, which is a 2.5 centimeter, probably mucosal prolapse, solitary ulcer, rectocele, enterocele. You can see in a demo. You can identify the megarectum in difficography, incontinence in difficography. There's no point of relaxing in a puborectalis, abnormal perineal descent, mucosal prolapse, solitary ulcer, rectocele, enterocele. Another investigation is sigmoidoscopy, which anal manometry, pudendal nerve latency study. So these are different investigation you can apply in the prolapse, but the main diagnosing point is the clinically. Clinically, you can diagnose the rectal prolapse. But if someone asks you in a question, if asked in an exam, what are the investigation? The difficography you can apply for the rectal prolapse. Other investigation is not applicable in a clinical side, but difficography is a choice. So treatment surgery is required, and so surgery is required. There now you can see in a complete prolapse, there's no any digital, there's no digital positioning or applying any injection. There's a surgery is required, and operation can be performed either via the perineal or abdominal approach. There are the two approach of surgeries in a complete prolapse. Either you can go for the perineal area or abdomen. So abdominal, now the abdominal rectopexy, rectopexy is simply a word which basically applying the rectum to the sacral area through stitches through different ways. So when you applying the rectum to the sacral area, yeah, when you applying anything to anything to fixing the any fixing anything within any area, it's called pexy. So if you are applying, if you are saying the rectopexy, that means you are fixing the rectum within somewhere. So this is called rectopexy. So abdominal rectopexy has a lower rate of recurrence, but when the patient is elderly and frail, the perineal operation is indicated. Ab- if if you're talking about abdominal rectopexy, it has a really lower recurrence rate, or it is a high successful rate. But when the patient is elderly, if a patient is elder and patient uh, can't tolerate the anesthesia, because when abdominal rectopexy needs anesthesia, general anesthesia. If a frail patient, if a patient who is a very frail or patient who is a very elderly, you cannot uh, tolerate the anesthesia, general anesthesia. So you can go for this. You can go through the perineal area. The perineal area is the area we can go through the spinal anesthesia. So that's why the perineal operation is indicated for those who cannot tolerate the general anesthesia, such as elderly and very frail. As an abdominal procedure, damage to the pelvic autonomic nerve resulting in a possible sexual dysfunction. Perineal approach is also usually preferred in young men. So the treatment is basically either the abdominal or perineum. Now, abdominal rectopexy has a lower recurrence rate. It's a very useful, but mostly to do in elder patients, in a frail patient, we can go for the perineum. And abdominal procedures has a lot of chances to damage the pelvic autonomic nerves, so it can cause a sexual dysfunction, impotency, and other incontinence, other urinary fecal incontinence. So that's why applying the perineal approaches in young patients are also preferred, usually preferred. Now, I will show you. I will mention the perineal surgery's name and abdominal surgery name. So at this time now, the perineal approach, there is a thoracic operation. This procedure basically aims to place a steel wire, or more commonly a nylon suture around the anal canal. Has become the obsolete. Why it is obsolete? Because it has a lack of popularity, but that the suture would often can break or cause a chronic perineal sepsis, or both, or it can cause anal stenosis. So created would produce a severe functional problems. So Dilorum operation is now the preferred perineal operation. The perineal approaches has a perineal approaches has a multiple operations. So perineal, if you are talking about the perineal approach, it has a multiple operation. One is a thoracic operation. In a thoracic operation, mostly what happens, the surgeons applying the steel wire or nylon or cylindrical sutures around the anal canal. So it becomes absolute because we don't know about the because it has a lack of popularity, and a suture can cause a sepsis or the stenosis, and so severe functional problems. So this is why they have absoluted. You can see here a thoracic operation. This is the anal canal, and you can see here, and this is anal canal, and they applying the sutures over there, over this area, and applying sutures over this area, and upper and lower areas, and they push and they're posing them rectum mucosal area inside, and they're tying the knot because it is narrowing the anal canal. It is narrowing the anal canal. The suturing basically applying the knot upper and lower zone, and they are tying it, and they are narrowing the anal canal. So it is now become obsolete, lack of popularity, and can cause a perineal sepsis and anal stenosis. So the thoracic operation is obsolete, and dealer operation is now preferred for the perineal operation. Dealer's operation, in this procedure, the rectal mucosa is removed circumficially from the prolapsed rectum over its length. The underlying muscle is then plicated with a series of sutures, such that when these are tied, the rectal muscles concentrate toward the anal canal. The anal canal mucosa is then sutured circumficially to the rectal mucosa, remaining at the tip of the prolapse. The prolapse is reduced and ring of muscles created above the anal canal, which prevents recurrence. So Dillon-Rom's operation, in this procedure, the rectal mucosa, which is the redundant, तो extra rectal mucosa था, उसको remove किया जाता है circumcision from the prolapse rectum. जो prolapse rectum का area था, उससे हम लोगों ने remove कर दिया over its length. So the underlying जो muscle थी, जो mucosa के circumficially remove करने के बाद, there was the underlying muscles. We have then applied, then plicated like we are going to fold it like a fold. You try to fold the paper. You can see there's a folding of the paper. This is called plication. So the muscles is then plicated with a series of sutures such that these are tied. We started the plication, and we applied the sutures over that area. Then the anal canal mucosa is then तो remaining anal canal mucosa थी. उसके बाद then we have then sutured circumficially to rectal mucosa. जो rectal muscles, जो this चीज rectal mucosa को अप्लाई किया, then anal canal की जो muscles mucosa था, इसको अप्लाई कर दिया, जिसके साथ जो rectal remaining जो rectal mucosa थी, जो एक तो we have removed the redundant mucosa. The remaining mucosa of the rectum, we apply the circumficially sutured vertebrae. The prolapse is reduced and a ring of muscle is created above the anal canal, which prevents recurrence. Simple though. It's called derome position. Derome position is nothing, just the excision of the mucosa. Remember that derome position is nothing, is the excision of the mucosa. And the thoracic position is nothing, just to narrowing the anal canal. These have both different areas. Okay, we are not applying any stitches outside of the anal canal. We are applying stitches over the mucosa area. We have just removed the redundant part of the mucosa, and we just placate the muscle of the muscle of the rectum inside. Okay. Now third one is ulterior position. It is also a perineal position, perineal operation. It is basically very helpful in a complete prolapse, in which you have to excise the whole sigmoid colon from the below and construction of colon anastomosis. Like you have to, this consists of excision of the prolapse rectum and associated sigmoid from below. Like a part, area of the rectum which is basically is prolapse, but with the whole prolapse of the rectum with extra part of sigmoid, with associated part of sigmoid which is involving the rectum with the prolapse, we have to excise it, and we are and then construct it with the colon anal anastomosis, the remaining part of the sigmoid with anal anastomosis. So the perineal approaches are the three operations: thoracic operation, delorums, and ultimate position. Now abdominal approach. The principle of all abdominal operations for rectal prolapse is to replace what? Replace and hold the rectum in its proper position. These are the principles. What are the principles for the abdominal position? To replace and hold the rectum in its position. They are recommended in a patient with a complete prolapse who are otherwise in good health. So abdominal operation for those patients who are very good in health, because they can tolerate the general anesthesia, we can apply the abdominal approach. Many variations have been described. There are many variations. They like a perineal operation. There are many variations. In a Wales operation, the rectum is fixed firmly to the sacrum. The rectum is fixed firmly to the sacrum by inserting a sheet of polypropylene mesh between them. Like in Wales position, rectum and sacrum both are fixed firmly and applying the mesh. And rapid operation involving the hatching of the rectosigmoid junction by Teflon sling to the front of the sacrum. Many surgeons simply switch the mobilized rectum to sacrum using 4 to 6 interpreted switches, non-absorbable switches, so-called sutured rectopex. Basically, they are recently the technique has been performed. Laparoscopy does the reducing the operative trauma and limiting time cost. Simply, in abdominal, nothing have to do, just applying the rectum to the sacrum. Either apply the mesh is called the mesh which is the polypropylene non-absorbable mesh. It is called Wells operation. Either applying the Teflon sling to front of the sacrum, applying retrosacral junction. It is called Rapestine repair. Either applying suture. It's called suture rectopex. So these all are the abdominal approaches. What are the complications of surgery? It can injury the hypogastric nerve. If you are doing the abdominal surgery, there are more reasons to damage the hypogastric nerve, and it causes the impotence, bladder dysfunction, bleeding from sacrum. If you are mobilizing sacrum, if you are getting a rectum from fixing the rectum to the sacral area, there are the sacral venous plexus which can cause bleed. Rectum, if you are applying the sutures to rectum, the sacrum, or applying the mesh to sacrum, you can injure the rectum and colon, causing the fecal fistula. Constipation of ectoplasy is also known complication. Recurrence can cause prolapse. Improper correction of continuous fecal ectoplasty infection and bronchitis, abscess, etc. It are the reason for that. So, the complication of surgery: damaging the hypogastric nerve, bladder dysfunction, impotence, bleeding, constipation, recurrence, infection, injury. You must remember all of these complications if you are doing the surgery of the prolapse. So, deficographic regarding, we have discovered deficograph. Deficograph It was a fluoroscopic investigation, X-ray investigation, applying the contrast in a rectal area and sitting position, then taking the pictures on a lateral position after. It can see the rectum, it can see the rectum position, rectum structure, uh, rectum, either rectum is a mega rectum, either rectum is a dilated or not, and you can see the levator muscles function, you can see the any other pathology related with the rectum. So there are the difficographic regarding rectal prolapse. Now you must remember that if there is a normal rectal fixation, there is a normal rectal fixation point. Rectum is not mobile, and sphincters are relaxing by its time, and the rectal is emptying. It's normal. So you can see the rectal is simply empty, getting empty. They are raising the tone. They are not. They are working tone of sphincters, and there is a normal rectal fixation is a normal N. You can denote it as an N. But if you are taking there's a sphincters are not relaxing well. So the non-relaxed puborectalis, you can mark one. There's a mild intussusception like a proximal part, it intussuscepted to the distal part, scale 2. If there's a moderate intussusception like a first second part intussuscepted 3 part scale 3. Severe में all of the three are intussusception with 6 and 4. If it occurs prolapse, it shows a 5. And a rectocele, you can see there's a rector is coming and then so now you can in a difficographic grading you can see there's a normal where the sphincters are releasing by itself, there is no any intussusception, so it's a normal. You can go for the, you don't have to worry about that. But so if the puborectal is not relaxing, one, if a mild is a 2, moderate is 3, and severe is a 4, if the prolapse is a 5, if the rectocele is a R. When applying the contrast on the rectal area, you can see you can now you can measure taking the images in different time. So in a in a very every time you can mark by yourself that it's a, either it's a relaxing, either it's not, either it's into suscepting or not, either it's prolapsing or not. So okay, so it is all about the prolapse. There's no any difficult you don't if you find any difficulty you can ask in a comment box. So it's all about the rectal prolapse, so easy, there's no worries. You must know about the must know about the operations, you must know about the clinical features, you must know about the what finding you can find in a difficography, and what investigation you are going to do in a rectal prolapse, what are the types of the rectal prolapse, and which surgery you are applying the for rectal prolapse, and which patient is suitable for the rectal prolapse. Like such as two types, partial, complete. So in a quick review, in a simple way, don't have to worry about it. In a quick review, you must know there's a two types, partial prolapse. In a partial, there's only mucosa. In a complete, the whole rectal wall comes out from the anal canal. In etiology, there's a decreased sacral curvature and a decreased anal tone. Malnutrited patient can cause. There's a decrease in epirectalis or levator muscles tone. There's a any cough, diarrhea. It's all the reasons. In a partial, there's a only pinkish area which comes out from the anus. Patient comes to you with a complaint of something coming out from the anus, which could be, and on a clinical exam, it can also associate with the bleeding. Prolapse can cause bleeding, can cause pain, can cause because discharge. So these are incontinence. These are the reason. These are the associated factors. You can ask on history. You can get it. On clinical examination, you can see there's a pinkish area. If you take about partial pressure, it should be less than 3.7 centimeter, less than 4 centimeters, less than two finger breadth, and the pinkish in color. So you can differentiate this thing from the hemorrhoid, because hemorrhoid is the same size. Hemorrhoid is the same size of it, but these are not circumferential, and the partial prolapse is a circumferential, and the hemorrhoids comes in a radially, and it is a pulp. It is basically a pulp, are blue color, and it is a pinkish color. Treatment: there's an infant and a child, you can go for digital repositioning and submucosal injection. After trial of the 1 month of the digital repositioning, you can go for the submucosal injection. And surgery is really required. You don't need to do a surgery. If you are doing it, you can go through the perineum area, putting a child in a pronate chair, apply the perineum, and you go for suture rectopexy simply. An adult local treatment is basically a submucosal injection. You can go either you are now another one is the excision of prolapse mucosa. You can apply that excision to the unilateral mucosa only. Either it is a whole covering it is a whole circumferential. You apply the mucosa into rectum and you apply the endoluminal stepping. And a complete prolapse is also called a procedetia. It is a more than 5 centimeter. It is a large. It also it shows basically a petulous anal sphincter, and it is associated with the uterine prolapse also. And and on examination you can feel any gurgling sound, because it comes with the peritoneum. It also is the same risk factors, some etiological factors: weakness, external factors, and pelvic muscle tone, obliterated and rent abdomen. Clinical features simply same, nothing more than rectal bleeding, sepsis, pain, complete fecal incontinence. PR, the anterior, you can see the legs sphincter. There was a decreased sphincter tone, and anteriorly peritoneal sac comes down as a pouch of Douglas. Investigation: defibrillography we had discussed earlier. Defibrillography is a choice of investigation. You can go for the defibrillography investigation. Is a contrast-based X-ray which shows you the different ways. It either shows the mega rectum, either it show you the incontinency, non-relaxing vigorectalis, penile descent, and solitary ulcer with the rectocele. Sigmoidoscopy, anal manometry, pudendal nerve latency period is also helpful. Defibrillography, these investigation can you see you can identify another pathology related with it, another disease associated with it. Surgery is required. Treatment: surgery is required. The operation can be performed by the perineal abdominal approaches. Abdominal rectopexy is a lower rectum, but it can apply to elderly or frail patients, so you can go for the perineal surgery. So perineal approaches, there are three procedures. We have discussed thoracic operation, Delorme's operation, ultimate operation, and a thoracic operation is simply it is an absolute operation. We are not doing the thoracic operation because it is narrowing the anal canal, which can cause a sepsis, which can cause stenosis. It is very difficult, and it is a very is a very dangerous if you are applying the suture in the anal canal area. Delor position is basically excision of the only part of mucosa, and the folding and application of the muscular cord to the remaining part of the rectum, and applying the anal canal mucosa to the circumferential to rectal mucosa, remaining rectal mucosa at the tip of the prolapse. This is called Delorme's operation. It is a very useful, and they are applying the Delorme position everywhere. And ultimate position, you have to excise the whole rectum with the part of sigmoid, with involving part of sigmoid, not all part, involving part of sigmoid is called ultimate position. An abdominal approach. This is a simply if you are applying sutures. Now you have the principle is that you have to position of the you have to replace and hold the rectum to the place. You have to replace the rectum and hold the rectum at that particular place, that specific particular its place. So applying suture rectum and sacrum is called suture rectopexy. If you are applying the polypropylene non-absorbable mesh between them, it's called Wells operation. If you are applying any Teflon sling hatching up retrosigmoid junction in front of sacrum, it's called Repustine repair. So recently, technique has been performed laparoscopically, thus using operative trauma. Complication: you must know about the hypogastric nerve injury, impotence, bleeding, bladder dysfunction, recurrence of the prolapse, constipation, And if you are injuring the rectum and the colon, it can cause fecal fistula. You can we have mentioned the phygographic stage is the different stages. So solitary rectal ulcer basically what? Now the another topic is we are discussing another topic which is called solitary rectal ulcer. Clinical condition characterized by the rectal bleeding, copious mucous discharge, anorectal pain, and difficult evacuation. Patient comes, a patient comes to you with a complaint of there is a bleeding per rectum, there is a mucous discharge, there is a pain, difficulty evacuation. So solid rectal ulcer syndrome can have a single rectal ulcer or multiple ulcers or even no ulcers. There is no ulcer, but patient comes to you with a complaint. Or multiple ulcers or solitary ulcers. When present, the ulcer usually occur at the anterior rectal wall just above the anorectal ring. This is an anorectal ring. What is anorectal ring? It's just a puborectal muscle which are holding the rectum or that area. This is called anorectal ring. It's the anus and rectum. The area which is the anum, which is the anal area, which is the 4 to 5 centimeter in length, and then after the from the anal verge, after the 4 centimeter of anal verge, there is a rectum area start. Rectum begins. So the anorectal area is that area which shows you the rectal and anal junction. So just above the anal rectal ring, anterior wall of the rectum shows you a simple single ulcer or multiple ulcers or nothing. Ulcer shows how ulcer appear. It's shallow lesions with a punched out gray white base and surrounded by the hyperemia. Around that ulcer there would be the hyperemic area and punched out gray white base region shows. The cause unclear. The cause is unclear. Associated with a chronic inflammation or trauma. Associated with a chronic inflammations or trauma. Internal susception or prolapse of rectum. Direct due to trauma or forced to evacuation hard stood. So cause we don't know about the cause. Cause is unclear. There is a cause, but it is associated with the prolapse of the rectum, internal intussusception, or chronic inflammations, or direct digital trauma or forces to evacuate the hard stood. So this you can see here. This is a basic image. You can see in this image. You can see in this image, this is a colonoscopy basically. You can see a sigmoidoscopy or colonoscopy. And you can see here images in this image you can see these folding areas. Or you can see here in this image it is not clear here and then you can go here. You can see this is a image of endoscopic area. You can see this area is a gray, this is a white area. Gray white area is a showing the ulcers. So management, what is management? Conservative therapy. Simple. Go for the conservative management. Or either the patient is associated with any pathology, you have to deal with that pathology. So what is the conservative management? Simply give the patient high fiber diet. Lifestyle changes should be start first. Like patient has a low patient ask the patient to eat a high fiber diet like a banana, like a bulk of stool, like a sagol, and ask the patient to change the lifestyle modification like eating vegetables and doing exercises uh, and increasing this activity. It is the first choice to do in a solitary rectal ulcers. If it's not helpful, then go for the pharmacological therapy. It's anti-inflammatory, enemas and suppositories. Limited success, but worth trying. If symptoms persist, localized resection may be considered. If symptoms persist, then you go have to resection locally, and patient with the prolapse need to be treated either the perineal procedures or abdominal procedures. Patient with the prolapse need to treated either with the perineal procedure or abdominal procedure. Thank you.